clinical hypothyroidism with the elevated TSH, but the T4 is within our normal value, anywhere from 2 to 5%, depending on your study. So for subclinical hypothyroidism, they had 2 randomized controlled trials, and again, there's a third out there that has not yet been published that showed no change in the IQ or cognitive outcomes when they compared to placebo alone. And of course, Dr. Scott touched on this earlier about randomized controlled trials not necessarily completely playing into our practice as well, so I'm sure there's a little bit of a grain of salt there. In terms of antibody screening, we know that 90% of women with Hashimoto's are going to have TPO antibodies. And we know that antibodies cross the placenta, and there's a theoretical risk of an increased spontaneous abortion in these patients. And so sometimes this can aid in the initial diagnosis. However, for patients that have subclinical disease, or for example, if you've screened for someone that has TPO antibodies but has otherwise euthyroid, we've shown that the treatment of these has not been shown to change cognitive outcomes in our children or our mother. So in patients who have a TPO antibody but are otherwise euthyroid, we do not recommend treating those women. And ACOG's recommendation there, again, matches up with their subclinical patients, and that we should not screen women for TPO antibodies unless we have a reason. So asymptomatic patients should not be screened. Moving on to the other kind of end of the spectrum when it comes to thyroid disease is Thyroid Storm. So this is going to happen in about 1% of our hyperthyroid patients. It's a rare hypermetabolic state. It can often be precipitated usually by some form of an extra factor. It could be infection, preeclampsia, maybe a second trimester surgery. And the labor component is somewhat scary because you never want to have a patient that's in labor that's in a thyroid storm. Symptoms can present with fever, tachycardia, which is often out of proportion to the fever itself. They can have altered mental status, vomiting, diarrhea, arrhythmia, seizure, and shock. And they can often present with an infectious sort of picture. The diagnosis is typically clinical. I added in certainly the elevated T4 and very low TSH values, but unfortunately we don't have labs that can get those back to us soon enough. So you definitely don't want to wait for labs in order to make this diagnosis. You've got to be aware of the patient that's at risk. So key points for this, a lot of times it can happen in untreated or undiagnosed hyperthyroid patients. Remember that the overall free T4 doesn't necessarily have to correlate with your outcomes. So we're looking for high numbers. We definitely want to get those back. They're going to come back after our diagnosis has been made anyways. If there is a precipitating cause, for example, an infectious nature, we want to treat that if possible, and certainly consider broad spectrum antibiotics if that's the case. And avoid salicylates, as that can increase the amount of T4 that's peripherally made. From a treatment standpoint, what are we going to do for our patient? So again, having a broad mind and approach to our patients and thinking that this is a diagnosis is going to be important. Starting them on PTU, the PTU load, then you're going to initiate them with iodine. You're going to try to saturate the thyroid itself and try to prevent any more thyroid hormone from being released from the thyroid itself. And that can be given in a number of different solutions. Steroids can be given as well to try and reduce that peripheral conversion into that kind of potent T3, and that's what the steroids are doing. Propranolol is going to be helpful in controlling mom's heart rate and her external symptoms that she's having. Phenobarbital can be given for restlessness. And I think number 6 is probably the big one. Like most things, avoid delivery. Even if you've got a bad category 2 strip, I liken a thyroid storm to something like a bad pyelo case. If you treat mom's acidosis, you'll fix baby's acidosis, and you don't have to deliver her. Even if she's 38 weeks, give her a week, let's get her out of her thyroid storm, and then deliver a healthy mom, and that's how we're going to have better outcomes. Moving on to thyroid cancer, just a few points here. It occurs in about 1 in every 1,000 pregnancies. One of the most important things I like to tell my patients is pregnancy itself does not alter the outcome. So it doesn't change based off of pregnant versus not pregnant. There was no difference in the tumor type, the size, the amount of metastasis, the time between the diagnosis and treatment, which is probably one of the biggest ones. Recurrence rates or deaths did not matter if the patient was pregnant or not pregnant. And so in general, pregnancy doesn't have to completely alter our management of thyroid cancer. Of course, we want to give them some form of thyroid suppression. They're typically going to present with hyperthyroidism. A thyroidectomy is certainly a possibility. Radiation is one of the other potential treatments, and so your timing is going to be based on your histologic results. What is your surgeon recommending, and then what are we able to recommend? And I suppose the biggest thing to remember is that I-131 is pretty much contraindicated. We do have the rare patient who is feeling better after their I-31 and decides to maybe stop taking their birth control and can get pregnant. And remember that going back to those first couple slides, is that the fetal thyroid doesn't take over until about 10 to 12 weeks. So there's the potential that you could be in a little bit of a safe zone depending on when the treatment happened. I think that's it. Happy to take any questions. Yes. Sir. Mm-hmm. That's a great question. So the question was phenobarbital versus maybe a separate benzo or other medication. And I'm not sure if there's a mechanism there for why phenobarbital was picked in that particular algorithm. I think a separate medication would likely be fine. I'm not aware of any contraindications of, from a thyroid conversion to benzos.
You made reference.
Mm-hmm. Oh, yeah. Yeah, certainly there may be some liver conversion there related to phenobarbital.
Dr. Gonzales, no one could hear what Dr. Adair said.
Oh, sorry.
Could you repeat it?
Yes, so the comment was about CYP450, the liver enzyme, discussion about phenobarbital and how it's broken down. That may be the reason why that particular drug was picked, and that it doesn't allow for any further liver conversion of T4 to T3, which is one of those big things that we're trying to prevent in a thyroid storm.
So you made reference to postpartum in a hypothyroid patient, but what about postpartum in a hyperthyroid patient? And is there any kind of algorithm or standard of care for that baby that's been born to a mother who's been taking these medications?
Sorry, so the question was for postpartum treatment of baby and mother in the immediate postpartum period?
Mm-hmm. Or does it change?
Yeah, no, that's a great question. So yes, so a patient who was still hyperthyroid would still require medication. If they were already on a dosage, I would probably drop them back down to their prepartum dosage of their particular medication. If they were diagnosed during the pregnancy, they would probably require a slight decrease depending on whatever their dosage was. And I typically would make that in the immediate postpartum period.
So you mentioned checking TSH in diabetes. Is that type 1 only? You mentioned the immune.
Yeah, that's a great question.
So what about type 2 diabetes?
So I think most of the studies would associate it with type 1 diabetes and being the true autoimmune component there, but thyroid disorders are still more common in our type 2 diabetes patients as well, and so I tend to cross those over, but most of the data comes from type 1 alone. All right, thanks.